right, good morning, everyone. I'd like to thank the Association for the honor of the podium. My name is Gail Gordillo. I'm an Associate Professor of Plastic Surgery at Ohio State. Today I'm going to talk to you about natural berry extracts as a treatment for hemangiomas. So a little background before we get started. I've been working on this for a while. The model that I use is a validated mouse model where I inject cells called eoma into mice and they make hemangioendothelioma. This is a validated model for hemangiomas because they share a common mechanism, which is high expression of this NOX4 that you can see by immunohistochemistry in our mouse model and in our human hemangioma tumors. These NOX4 produces hydrogen peroxide directly in the nucleus of these tumor-forming endothelial cells, so that's an important concept. I recently published a paper in the Journal of Biological Chemistry showing that one of the responses to this high oxidative load is that you have an increased expression in a protein called multi-drug resistance protein 1. That drug is a pump. It pumps chemotherapy drugs out of cells. It pumps toxins out of cells, hence the name multi-drug resistance protein. What we showed is that this protein, the way it works in these tumor-forming cells, is it pumps oxidized glutathione, which is a buffer, essentially, out of the nucleus of these cells so that they don't die. And so my question was, with our berry model, and we have some other data that I've published that shows that it potentially can inhibit tumor formation. So my question was, do the berries inhibit this multi-drug resistance protein 1 that is a key compensatory pathologic response that allows these cells to survive? So the first thing we did was a dose response curve and toxicity, and so we did an LDH assay, and here the doses are going up from 25 to 50 to 100 micrograms per mil of the berry therapy, and you can see we get a nice increase in toxicity in our eoma cells, our tumor-forming cells, our control cells, our mouse aortic endothelial cells, and relatively unaffected. We then looked at whether or not the berry therapy decreased MRP1 activity. We used what's called a calcium exclusion assay that you measure by flow cytometry. And again, increasing exposure to the berry therapy in a dose response curve showed a nice dose-related inhibition in MRP1 activity. We then wanted to see if this loss of activity was related to loss of protein expression. We did qPCR and showed decreased mRNA with exposure to the berry therapy and decreased protein levels as well on Western blot, as shown here, when the eoma cells are exposed to the berry therapy at 50 micrograms per milliliter. I mentioned previously that the MRP pumps oxidized proteins out of the nucleus, so we wanted to see if the berry therapy affected nuclear localization of MRP1. We used some immunofluorescence microscopy, and here you can see the blue is a nuclear stain called DAPI, and the green is the MRP1. And as you can see in the vehicle-treated controls, lots of green and blue together. In response to the berry therapy exposure, you have significant decrease in the amount of green pixels, which we've quantitated here to show there's a significant decrease in MRP1 protein in response to the berry exposure. We then used software to co-localize the MRP1, the green pixels, with the blue pixels, the DAPI. And those pixels that are overlapping come out as white. And so you can see there's a significant decrease in the MRP1 co-localization with the nucleus in response to the berry therapy, and so this is quantitated here. We then wanted to show that this loss of MRP1 function, again in response to berry therapy exposure, resulted in accumulation of oxidized glutathione in the nucleus of these cells. And so we did subcellular compartments. We took these cells and measured the oxidized glutathione, here indicated as GSSG, and the reduced glutathione in each compartment. Cells were exposed to either the vehicle control, the berry therapy, or BCNU was a positive control. That's an enzyme inhibitor that prevents the reduction of oxidized glutathione to reduce glutathione, so your oxidized glutathione should build up in response to that treatment. What you can see here is that in the cytosolic fraction, very little oxidized glutathione, which is the way it should be in natural biology, and then in the nucleus, in response to the berry therapy, significant accumulation of oxidized glutathione, essentially no changes in the reduced glutathione state, and then this ratio of oxidized to reduced glutathione is an indicator of oxidative stress. when you look specifically at the nuclear compartment, substantially increased in response to the berry therapy here. And then we just did a ratio of the oxidized to reduced glutathione and then nucleus versus the cytosol, and again, a substantial increase in response to exposure to the berry therapy. When cells are exposed to high levels of oxidants, the mechanism of death is typically apoptosis, and we wanted to confirm that that was indeed the mechanism of toxicity in these cells. We looked specifically at 3 proteins, BAX, caspase-9, and cleaved caspase-3 as sequential steps in the apoptosis pathway activation. This figure A is just our Western blot to show you the bands for each of these significantly increased in response to exposure to the berry therapy. We quantitated that with pixel densitometry, as you can see here. And again, all 3 proteins substantially increased in response to exposure to berry therapy. And we repeated that with immunofluorescence microscopy. Again, BAX in green, caspase-9 in green here, and elevated cleaved caspase-3 in red here. And using pixel densitometry, all of these apoptotic pathway proteins are elevated in response to the berry therapy. To see if there was any effect in vivo, we took these cells that we had treated in vitro and injected them into mice. This is just an example of the tumors that we develop. If we looked at the tumor size at 10 days, which we picked because that's when the control mice start to die, you can see the tumors are much smaller, and you can see that even the in vitro pretreatment without any in vivo exposure provided a significant survival advantage to the mice that received cells exposed to the berry therapy. We then took those 10-day tumor samples and wanted to confirm that there was apoptosis in these samples. And again, here are the berry therapy and the vehicle controls, green BAX, green here, caspase-9, and the red caspase-3. That is the final step in the apoptotic pathway, and all are substantially elevated in these tumor cells. And Western blot on the tumor cells shows a substantial decrease in MRP1 in these tissues as well. So in conclusion, we found that berry therapy treatment inhibits MRP1 expression and activity. It leads to apoptotic cell death via nuclear accumulation of oxidized glutathione, and it inhibits endothelial cell tumor growth in vivo. And while those are the conclusions of the experiment, what's more important is the significance. So we identified a novel compensatory pathway that allows cancer cells to survive an onslaught of oxidative stress, which is a common finding in tumor-forming cells. We identified a nutritional intervention that targets that protein. And because this protein is so highly expressed in other tumors, we believe that this therapy may have application for other tumors, and that it also may have application as an adjuvant because, as multi-drug resistance protein 1 does, it excludes chemotherapy from cells. So we may be able to inhibit this protein, increase the effectiveness of chemotherapy, and reduce the effects of chemoresistance. Thank you.
This paper now will be discussed by Dr. Anaya.
Thank you very much for the opportunity to discuss drug palarinase, Vancouver, British Columbia. My disclosure is that I'm not a basic scientist, but I certainly treat a lot of children with hemangiomas and have in the past and will continue in the future. So the interesting discussion about hemangioma is that it's a very enigmatic tumor. We don't know who's going to get the tumor. We don't know how large it's going to be. We don't know when it's going to involute. We don't know what treatment is going to be efficacious and what complications are going to develop. The interesting thing about hemangioma treatment is to have a discussion about the history. And when you look at the 50s and 60s, you see that these tumors were treated with radiation, and of course that developed significant disastrous complications. A hands-off approach followed through the 70s and maybe early 80s. Ultimately, steroids, interferon, vincristine, all were treated with some degree of success, although none were ideal. Ultimately, I had the opportunity to sit in the audience in Boston in 2008 when propranolol was described by the 2 groups at the ISFA meeting. And what we've seen at the present time, at least at the clinical vanguard, is that propranolol is first-line therapy, and it has largely replaced surgical therapy for these tumors. So I was most intrigued by your paper, and I congratulate you and your team on your work. The questions I have for you are, it's still not clear why the beta blockade works for propranolol in the treatment of hemangioma. So what is to use the word secret sauce, what is the secret sauce of the berry treatment that you would guess if you put your bet on what's the theory as to why this might work. That's my first question. The second question is, in any new drug discovery, quality and safety are paramount metrics. And so is there any side effects that you could describe as a limitation to this? And my final question is, where do we go from here? You know, in a translational way, our goal is to take something that we see at the bench and obviously get it out to market. And if we can find something, not that propranolol is not a safe drug, the complication profile is very well established, but where do we go from here?
So I'll take them sort of in order. The first one, in terms of what's the secret sauce. So there's been lots of work in the cancer biology field about these natural products, and most likely it's anthocyanins. I think one of the things as scientists we tend to be reductionist. I actually have pharmacokinetics based on an anthocyanin profile, so I know exactly what the composition of this berry therapy is. And we're doing some other experiments where we're using individual anthocyanins to see if we can get these effects. But my comment would be that it's a food, and the minute that you try and break it down into those individual anthocyanins, you lose that sort of synergism. So lots of data that would suggest that anthocyanins are the most likely active ingredient. In terms of propranolol and the secret sauce with this, I think the MRP1 inhibition is the secret sauce. And lots of discussion has been around natural products and their antioxidant effects, but this is the mechanism through which they are blocking those or disrupting the antioxidant chain. And so that's really the key thing, is you can see that this induces cell death. I think most of the other natural products were stopping growth or inhibiting the transcription factors that promote growth. This induces cell death, so I think that's important. The last one, where are we, how are we going to, what's the next steps? So this product comes from I obviously don't make it. It's a very simple berry extract. The product is FDA GMP approved. The vehicle that I use, so this is an in vitro study, but the vehicle that we use is also FDA GMP approved. And so I'm actually in the process of going to the FDA for an IND to do the first clinical studies. I presented 2 years ago that I have a biomarker in the urine for these patients, microRNA 126. So I now have a biomarker and I now have a therapy, and we're going to put those two together and start the trial.
Gail, most of my questions have been answered since I've been standing here, but thank you so much for your work with this over the years. Are you adding anything to the berries, or you just squash them and rub them on? That's number one. Number two, does it matter what the time frame is? You know, hemangiomas go through a proliferative phase, and does it matter if you start early on or if you wait a few weeks or months or something?
So one of the things that we do is you can, obviously in an experimental model, which we have, you can completely block the development of these tumors, but that's not what you see clinically. So when we do our in vivo models, when we treat in vivo, when I didn't present that data here, we wait until a tumor is formed. So we're actually inducing regression of the tumors. And so from that standpoint, I think that is a more clinically applicable model. And I didn't, like I said, haven't published it, I haven't shown it here. And I haven't published it yet because my grant is not yet funded, but soon to be, and then I'll put that data out. But, you know, and then the berry preparation itself, so it's basically a very simple acetone extract. I mean, this is nothing but powdered berries. And we mix it with a hyaluronic acid that we put, we give it topically when we do it in vivo, and get great absorption. And I do have the ability to measure the pharmacokinetics with an anthocyanin profile with this product.
Thank you.
Thank you.
Okay. One quick question.
Oh, me? Oh, okay, thanks. Paul Liu from Brown. Gail, excellent work. Obviously, I've waited to hear this presentation for a while, and I congratulate you on it. Knowing that you collaborate with Chandan in his fascination with inhibition of mRNA and things, compare this to the knockdown that you get when you abrogate the RNA expression with miRNA.
So we do have again, another more work that's in my grant but not yet published. So there's a microRNA that really drives this. It's microRNA 126 is what we're detecting in the urine of these children. I don't have the connection yet between my berry therapy and microRNA 126, but I have done what's called a nanostring, so we've done the berry therapy and screened for the microRNAs, so we're going to start exploring that. But I will tell you, you can get, if you knock down the microRNA, you can also get a complete inhibition of tumor growth, like complete resolution, just like this. So it's another tool in our armamentarium that we're developing, but I haven't found the intersection of these two yet.
Thank you.
But this one, I think, goes to market easier than the microRNA.
Okay, thank you very much.
Thank you.
Next paper, analyzing the correlation of 5 indications to the regenerative effectiveness of expanded skin, will be presented by Dr. Xiangbei Zhou from Shanghai, China.
Thank you very much. Good morning, everyone. First, I'd like to thank the committee to give me this chance to sharing our recent research with us. And I am from Shanghai, China, Shanghai Nice People's Hospital. We are now one of the biggest plastic centers in China. So what we are facing every day is like this. We are treating all kinds of large-scale skin deficiency patients from all parts of China. So this is quite a challenge work. With the help of skin expansion, we know we can provide the better clinical outcomes for the patients. It's pretty quite good treatment, but still in some patients, skin expansion appears to have severe complications, including thinning, ulceration, or even necrosis. So here we check out what the cause of these problems. We can see these problems are all because of lack of the regenerative capacity. So here come to our question: how can we evaluate and predict the regenerative condition of the expanded skin? How we can avoid these kind of problems? We can check out first for the normal expanded skin. We can see these, here are 5 indications that we measure. They must be pink in color, no sign of stretch marks, skin lesion, vessel varicose, or even the mark of thinning. So according to our clinical observations, we graded all these indications into 3 grades. The best is none, then the mild and the severe conditions coming with the pictures. Here I am sharing with you with this retrospective study of 277 expansion cases. We evaluated the condition of expanded skin, and also we evaluated the correlation of these indications to the skin condition. First, we can check out the basic descriptions, and we divided these patients into different age, gender, locations, and if it is a first or second expansion. In this part, we analyze the relation of the age. We can see in younger patients, they have better skin textures. And while coming to the gender, we find that male patients were more prone to have deteriorated expanded skin than women. It's interesting. And when to the expansion time, the first time and second time, they does not have relative to the skin texture. So when it comes to different locations, we'll find that it means quite a lot. We can find that in scalps, in the forehead, skin texture is very good, but when into the neck, back, cheek, something worse happen. So we find out the overall occurrence of each indication is very different. The most commonly observed ones is thinning and the vessel varicose. Then we divided these patients by the expansion locations. First, we find that in neck, the thinning and varicose, they were most commonly seen, and the high occurrence rate in severe ones. Also, in cheek, thinning and varicose is one most huge problems here. But in chest, it changed. Stretch mark and thinning was the 2 most severe questions, and in hind lips, it's a similar situation. But another interesting thing is, while it comes to back, thinning and varicose not commonly seen, but the stretch marks is one of the most commonly observed severe indications here. The abdomen, forehead, they are good in condition. No severe indications were observed. the most important part, we tested the correlations of these 5 indications to the overall prognosis of the expanded skin. We find out all these 5 indications were tightly correlated. So we, based on these results, we developed this rating system. We divided the skins to 4 different grades, so we can see from the good to the most urgent situations. So how we can use this system is how we can predict the regenerative capacity of skin so that we can try to prevent grade B expanded skin deteriorated to grade C and try to rescue the expanded skin in grade C. We tried several clinical interventions. One potential intervention may be the stem cell treatment. We reported this clinical trial 2016. And using the autologous stem cell graft intradermally, we find the skin increased in thickness, and also we can see the texture has improved. So here are some other potential interventions we are testing either in our animal model or in a clinical trial. That can be SVF from the fat tissue, the PRP from the blood, and maybe other stem cells. Based on this rating system, we try to propose a clinical strategy that we can give the patients different interventions according to different grades. So whilst in best grade, grade A, they can undergo in the regular expansion. When it comes to grade B, they mildly deteriorated. The expansion stopped, then give him 2 weeks of observation. If it's still deteriorating, then give him the stem cell intervention. When it comes to grade C, the severely deteriorated ones, stem cell intervention must be performed immediately. But the last is grade D. It's a very urgent situation. Then we need to determine skin expansion immediately and perform the fat transplantation. I'd like to thank all our team members for the contributions, and thank you very much for your patience.
This paper will now be discussed by Dr. Ed Lee.
Hi, Dr. Dowd. Thank you very much for your presentation. We've all struggled with tissue expansion and what to do when the skin starts to look awful. Your case examples are phenomenal. And so you created a grading system for examining the skin. So one of my questions with that is, did you also create a grading system for the skin before you started the expansion, and what were the characteristics of that skin prior? Because that obviously will determine some of what happens in the future. 2, you sort of glossed over your intervention with the stem cell therapy and what you were doing to try to recover the tissue expander as the skin started to thin and develop complications. If you could expand on that, that would be fantastic, because, I mean, you were able to salvage a good number of them. So if you could answer those 2, that would be fantastic.
Thank you very much, Dr. Lee, for your questions. First, you suggested very great. It's very good because we have not yet evaluated the pre-expansion condition of skins. As we know, the problem of expansion skin usually comes to the mid-term of the expansion, usually like 2 to 3 months after we started the expansion. So that's why we mainly focus on the ongoing expansion skins. Well, your question is very, very interesting because as we observed in our clinical performances, we find that one of the most important is to the procedure is like the location of the skin. As we know, also the blood supply of the expanded skins. Well, as you suggested, we can try to evaluate the pre-expansion skins ahead of the procedure, and it may help to maybe I think we can. One is to first we can evaluate the blood supply. If we know that as the forehead is expanding with the muscle is much better in the texture during the expansion. That's why these severe indications were seldom seen in forehead. Also, the other part is we can test the skin thickness ahead of the expansions. So this will help to evaluating the expanded skin conditions before we can perform the procedure, and we can probably make the best decision in locations selections for a patient. And for the second question, well, we have now reported one clinical trial of using the autologous normal nuclear cells from the bone marrow and treating the expanded skin with deteriorated in conditions. So this is how we make the procedure. We separated the stem cells from the bone marrow and transplanted into the expanded skin intradermally. And the enrollment of these patients, one thing while we enroll these patients is the patients with deteriorated skins. So that's when we giving these treatment to these patients, they have the increase in the skin thickness, then the increase in the expansion volume and the area of expanded skins. Also, we are now testing several others, as I just introduced. We are now having an ongoing clinical trial using SVF from the fat tissues. We have reported the very good outcomes from the preclinical research using an animal model. That's now why we are testing the clinical effect of the SVF treatment in our patients currently. So maybe I hope next year we can show more data about this treatment. Thank you very much.
Thank you. So my thought was that if you're able to predict which skin is going to do poorly, can you pre-treat before the expansion with your bone marrow-derived stem cells and then not end up being in a position where you're then rushing to try to salvage the expander?
Yes, but technically it's a little bit hard because we know we can not only select the site of expansion due to the skin texture, but also we have to consider about the if it's nearby area or it has the most closed color or texture to the reception site, and as well as we have to consider about the blood supply. So yes, I think your suggestion is very good, and we can see how we can make it. But still, I think some more aspect we need to do with the selection of the expansion site. Thank you.
We have one comment from the tweeting questions. Like you mentioned before, is there any relationships of the expansion volume regarding your strategy? So for example, if you want to expect certain degree of expansion, any strategy that you stratify along with?
I have to say that the volume is really a important thing to the expansion, because as we know, the larger the expansion goes, the more skin area we can get. And using this strategy is the most convenient part is that the volume doesn't matter. We just evaluate the text. If the text is good, then we can keep going the expansion. So that's the greatest part of this evaluation system. And also, I think the problem usually, in China, we usually go over expressions, not like the United States. We usually go 2 to 3 times of the expansion, and so that's why we comes all through all these complications, higher than the United States, and that's why we are developing this system to do more what we can do to give the clinical patients.
Thank you very much.
Thank you.
All right.
The next paper will be Modulating TAC1 Signaling to Enhance Scaffold and Cell-Free Calvarial Healing by Dr. Benjamin Levy.
Thank you for giving us the opportunity to talk at this prestigious meeting. As a disclosure, we are collaborating with a company, Boehringer Ingelheim, on a project whose work is not presented here. Calvarial defects have a number of etiologies, including infection, tumor, trauma, and craniofacial reconstruction. With the advances of neurotrauma and early surgical decompression, rates of trauma survival have increased, but patients who have craniofacial trauma such as this are left with large bone defects. In the craniofacial side of things, in pediatric patients, bone grafting, autologous bone grafting is often the treatment of choice, but resorption rates in kids are up as high as 50% compared with 6.5% in adults. So it's a very reconstructive challenge for plastic surgeons treating such patients. Biologically, we know that calvarial defects heal through intramembranous ossification, where we know mesenchymal cells from the dura, the osteogenic front, and also from the suture, Gli1 positive mesenchymal cells, lead to healing of calvarial defects. However, the advances in bone tissue engineering with stem cells and scaffolds have led engineers to try to recreate and regenerate bone tissue through the use of mesenchymal cells harvested from fat and also bone marrow, and implanting these on hydroxyapatite-coated PLGA scaffolds. Interestingly, though, we found that chronic defects, even with the help of stem cells and these scaffolds, don't heal over a period of time. So there's something very intriguing in acute injuries. The inflammation process itself is causing a change in these cells, in the mesenchymal cells, to undergo differentiation. So we turned our attention to a molecule that's actually been of interest in the developmental biology world. It's called TAC1, and it stands for TGF-beta activated kinase 1. In developmental biology, the literature suggested that TAC1 is a mediator of both proliferation and differentiation of mesenchymal cells in the articular cartilage and also in long bones. However, no one has studied this in injuries or in the setting of wound healing. So we turned our attention to TAC1 because it is a mediator of both TGF-beta and BMP2, which are both important in the bone healing process, both for endochondral and intramembranous ossification. So to confirm what the developmental biologists found in the literature, we harvested mesenchymal cells from a global knockout mouse model of TAC1. And we did this using a ubiquitous Cree TAC1 mouse, and we took their cells and let them undergo osteogenic differentiation. And as you can see on the right, the mutant which had the TAC1 knocked out had less osteogenic differentiation, indicating that TAC1 was essential for osteogenic differentiation. Interestingly, though, when we looked at proliferation assays using BRDU, we noticed that the TAC1 knockout mouse actually had increased proliferation. Also, Western blots looking at PAKT, which is a marker of proliferation, showed the same trend. So then we asked the question if modulation of TAC1 is in a sequential pattern could lead to healing of calvarial defects without the use of scaffolds and without the use of cells, which are currently not FDA approved. Using a novel dual-recombinase system developed by one of our collaborators, Dr. Machina, in the dental school at Michigan, we set out to answer this question. There had never been a system before which allowed for a gene to be turned off and back on, and this is what this system allowed. So using this, we again looked at in vitro studies where we first used Cree recombinase virus, noted here by ADC, and also the flip-base virus, which is noted by ADF. And what the Cree did, which was knock down the TAC1, and the flip-base was used to knock and reactivate the TAC1 signaling pathway. And as noted here, again, as we saw previously, the AD-Cree virus, when we knocked out TAC1, we saw decreases in osteogenic differentiation. But when we flipped TAC1 back on, the osteogenic differentiation capacity was restored. Similarly, with proliferation, we saw that knocking out TAC1 increased proliferation, but knocking it back in with the flip virus actually decreased it, as shown by the Western blot and also by qPCR. So this is essentially what we wanted to do. In any given wound, you first want to fill the defect with cells by causing the cells to proliferate and condense into a mesenchymal fashion. And then you want to eventually, over time, cause these cells that have gathered there to differentiate into the tissue of your interest. And so the proliferation occurs early on, and then the differentiation occurs later on, and that's kind of what follows TAC1 expression. So using the critical size calvarial defect model, we tested this and translated our in vitro findings to an in vivo setting. And on day 0, these mice got bilateral calvarial defects, along with induction by the 3 viruses, AdLAC-Z, which was our control, AdCRE, and then AdCRE flip. And the flip virus was used to flip the TAC1 back on at day 7. And we followed these mice out to 9 weeks. At that point, we did CT scanning, and we also did immunohistochemistry with immunofluorescent staining. And we chose to look at bone differentiation markers, both early with osterix and late with osteocalcin. And again, as with the in vitro findings, the in vivo findings showed the same thing, where when we used the flipase to turn the TAC1 back on after a period of 7 days of turning it off, we saw increases in bone regeneration at the osteogenic front. And on the right-hand side, we also chose to look at proliferation with Ki67, which is a common immunofluorescent stain used to look at proliferation. And we notice here that there's a lot more proliferation when we knock out TAC1 with the CRE virus, but when we flip it back on, the proliferation went down significantly. And so our CT findings showed this, and as you can see, at 9 weeks, there was much more bone that formed with the mouse group that received both the CRE virus and the flip virus after 7 days. And this was also confirmed with histomorphometry using aniline blue staining, which stains mature collagen. And it was significant. So where does this leave us? So this leads us to say that TAC1 can be modulated and mediated therapeutically to first cause cellular proliferation and then cause differentiation in a synchronized fashion. One of the future studies that we're trying to look at is to see if there's a therapeutic that can mimic what we found with our adenovirus model. And one of the drugs, unfortunately, that we're currently looking at, NG25, does not mimic proliferation, but it does, when you use it, decrease osteogenic differentiation. So if there was a drug that we could use to knock out TAC1 initially in the early phases of wound healing, and then withdraw the drug later on, we could stimulate what we found in vivo. In our future studies, we're also looking at HO model, heterotopic ossification, which is found in 1 to 3% of burn trauma patients, to use TAC1 and knock it out and see if we could prevent this pathologic process. And I'd like to thank Dr. Levy, Dr. Buckman, Sederna, and the rest of the UM faculty for giving me the opportunity to present this.
And our discussant is Dr. Henry Shah.
Yes, that was wonderful work, very impressive. And I have to say, I congratulate you not only on these remarkable results, but the hard work and perseverance that it requires to follow through on something like that. Actually, it reminds me of one of my favorite movies growing up, The Karate Kid, because there, it was also all about persevering and a model which, at least you didn't mention in your talk here, but you had talked about a drug-on, drug-off paradigm, which I think has very far-reaching, powerful implications. And of course, if you know the movie, there was this wax-on, wax-off model of achieving success. So I think there are great implications. My questions have to do, if you could elaborate a bit more on chondrogenesis, right? The relationship, obviously, that's an important part of osteogenesis, and what TAC1, how that relates to that. And also, is there any crosstalk with other pathway, like induced by leptin or HIF1 alpha, and whether that might have some potential role in helping you achieve a therapeutic strategy?
Sure. Thanks, Dr. Shah. To answer your first question, and also I do like Van Wilder, so I did like the wax on, wax off quote that you used there. But to answer your question about chondrogenesis, we are looking at, as I said in the future studies, a model using heterotopic ossification. In this model, we do a 30% total body surface area burn on the dorsum of a mouse, and then we cut the Achilles tendon using a tenotomy. And over a course of 9 weeks, they develop a process, ectopic bone through endochondral ossification. So we do study chondrogenesis in that model, particular setting, and TAC1 does seem to play a big role in that as well. As far as the future studies go, I think, as you mentioned, maybe looking at more so the timing of when to knock out TAC1 at certain weeks, either before or after the chondrogenesis period has occurred, leads to any differences in heterotopic bone formation will be important. But it certainly does have an effect both on chondrogenesis, mesenchymal condensation, and ossification as well. To answer your second question about whether we have looked at TAC1 and seeing if it affects other signaling pathways, we have previously looked at HIF1 alpha in our HO model. We have not looked at, though, TAC1 and its relationship to HIF1, but we certainly are looking to see if TAC1 affects other downstream pathways, because it's a mediator of both TGF-beta and BMP2, but it certainly does affect other downstream pathways, including like mTOR and some of the SMAD proteins, which obviously go past not only TGF-beta and BMP. So it's certainly something we are working on.
Okay. Thank you very much.
Thank you.
Next is dipyridamole containing 3D printed bioactive ceramic scaffolds for the treatment of calvarial defects, an experimental study in sheep, presented by Jonathan Beckish.
Good morning, everyone, and thank you for having us. Bony defects of the craniomaxillofacial skeleton, secondary to congenital conditions, traumatic injuries, and the surgical treatment of oncologic disease are common, costly, and often difficult to treat. Autologous bone grafting is a common first-line treatment. However, each procedure is associated with 2 surgical sites and the risks and morbidity that accompany this. Further, many patients require multiple bone grafting procedures over the course of their lives. Thus, there is an obvious need for treatments that circumvent some of the drawbacks associated with autologous bone. Among the current options that exist, allografts and xenografts offer natural therapies. However, their potential for immunologic reaction and an incompatibility with the belief systems of certain patient populations limit their applicability. Synthetics are generally grouped into 3 categories: metals, polymers, and ceramics. However, with each there is a known risk of infection, extrusion, and an inability to grow with the pediatric skeleton. Therefore, when seeking out alternative therapies, it is important to shift the treatment focus from those that simply fill defects to those that integrate with the native anatomy. The field of bone tissue engineering aims to accomplish this by restoring deficiencies through the genesis of vascularized bone. Biomaterials such as beta-tricalcium phosphate often provide an osteoconductive foundation in the field of bone tissue engineering. The images below depict our work with a beta-tricalcium phosphate scaffold in a segmental radius defect in a rabbit model. At both time points shown, there is no evidence of an inflammatory reaction or ectopic bone formation, and by the 24-week postoperative period, there is significant evidence of lamellar reorganization with bony bridging across the scaffold and angiogenesis. When working with 3D printers such as the one depicted here, it is possible to create customized biomaterials-based scaffolds that take advantage of geometry in their design so as to maximize osteoconductivity. This image depicts a 3-dimensional reconstruction of the scaffold created for this particular study presented today. Designed like an inverted top hat, it possessed a solid beta-tricalcium phosphate cap superiorly with a plug that extended inferiorly into the calvarial defect surgically created. An emphasis was placed on the overall macrogeometric structure designed to fit and fill the defect, as well as a lattice-based mesogeometric structure with struts and pores spaced so as to optimize osteoconduction according to previous work in a rabbit calvarial model. There is great value in the ability to augment tissue engineering constructs, such as through the delivery of drugs or growth factors, enabling one to modulate the biochemical pathways involved in bone formation. To this end, much work has currently been done with recombinant human bone morphogenetic protein 2, which has demonstrated encouraging results and shown a robust potential for osteogenesis, however, has also been affected with adverse effects such as ectopic bone formation and the induction of craniosynostosis. Thus, to date, the ideal augmentative agent in bone tissue engineering has remained elusive. The purine nucleotide adenosine has recently come to light for its role in a number of key pathways involved in osteogenesis. In particular, the adenosine A2A receptor, present on both osteoblast and osteoclast precursors, as well as endothelial cells, has garnered attention for its role in a number of key pathways involving bone metabolism and angiogenesis, an inhibition of bone destruction by decreasing the function and number of osteoclasts, the promotion of bone regeneration, and a dampening of the immune response by decreasing the function of both macrophages and neutrophils, as well as decreasing the release of inflammatory cytokines. Therefore, there's a potential role for agonists of the A2AR in the field of bone tissue engineering. One agent of particular interest is dipyridamole. Marketed for decades as Persantine, an antithrombotic and vasodilator, with a long history of safe use in both adults and pediatric patients, dipyridamole has recently come to light for its osteoinductive properties. Acting as an indirect agonist of the A2AR, it promotes an increase in extracellular adenosine concentration via a reuptake inhibition mechanism involving the transporter ENT1. It was this understanding that led us to the research question that drove the study presented today, which is whether or not the addition of dipyridamole to 3D printed beta-tricalcium phosphate scaffolds with known osteoconductive properties would increase bone regeneration in the calvarium of a large translational animal model. Our study cohort consisted of 5 skeletally mature finished Dorset sheep, and our surgical intervention involved the creation of 11 millimeter calvarial defects, followed by scaffold implantation as depicted below. Our control scaffolds were composed of 100% beta-tricalcium phosphate coated in a bovine collagen solution, and our experimental scaffolds were composed of 100% beta-TCP immersed in collagen, and then further immersed in a 100 micromolar concentration solution of dipyridamole. This schematic depicts our study design, with the anterior-posterior distinction denoting whether or not a scaffold belonged to the experimental or control group, and the right and left sides of the calvarium denoting the time from scaffold implantation to animal euthanization. Of note, the anterior and posterior samples were spaced approximately 1 to 2 millimeters apart to ensure anatomic homogeny between the sites. This image depicts a histologic slide from a scaffold belonging to our experimental group at the 6-week time point. We performed histomorphometric analysis so as to quantify the relative percentages of bone, scaffold, and soft tissue present in each of our slides. For your reference, bone stains in pink, the scaffold is stained in black, and the soft tissue stains in bluish-green. We analyzed 3 different regions of interest, the first comprising the entire diameter of the scaffold, including the cap, the second composed of only the core of the scaffold minus the cap, and the third encompassing only the middle 50% of the scaffold's diameter, which enabled us to assess differences in bone growth formation in various regions of the scaffold. Representative slides from each of our 4 groups are shown here. Of note, there was no evidence of an inflammatory reaction in any of our groups, nor any presence of exuberant bone formation. On histologic analysis, we observed a pattern of osteoconduction along the scaffold, as well as significant woven bone formation with lamellar reorganization, the development of osteons with Haversian canals, and angiogenesis. This chart shows the relative percentage of bone surface area occupancy averaged across all 4 groups in looking at the various regions of interest studied. Of note, there was a significant increase in bone formation in the dipyridamole-containing scaffolds compared to controls at the 6-week time point. This effect was most pronounced in the center of the scaffold, where in the middle 50% region, we observed a greater than 90% increase in bone formation in our dipyridamole-containing samples at 6 weeks relative to controls. In summary, dipyridamole significantly enhances bone formation compared to controls at 6 weeks. The effect of dipyridamole was most pronounced in the center of the scaffold, where we observed a greater than 90% increase in bone formation relative to controls at the 6-week postoperative time point. And we saw no evidence of an inflammatory reaction or ectopic bone formation in any of our samples studied. In the future, we would like our work to extend to include the use of true negative controls in all of our samples, as the critical size defect in the sheep has previously been described at approximately 20 millimeters. Variation in our scaffold design, such as the use of a porous cap and/or walls, could provide interesting changes to our results observed. We would like to expand the use of this tissue engineering construct to other areas of the craniomaxillofacial skeleton, such as the alveolus or the mandible. And further, we would like to test the ability of our dipyridamole-coated scaffolds to address the very specific needs of the pediatric population. Thank you very much for your time and attention.
And our discussant is Dr. Gail Gordillo.
Thank you. Nice job. Very nice presentation. A couple questions. Were the skull defects full thickness or partial thickness?
They were full thickness.
Okay. And I think there's an assumption that your dipyridamole is coming out. Did you do any in vitro bioassays or anything to make sure that the dipyridamole that you put in the the 3D printed construct actually gets expressed out of the device?
That's a very good question. It's actually something that we're currently continuing to study. There's been a previous study that looked at diprotamol release over time, but we wanted to do something a little bit more formal within our group. So that's an area of future work. I think you raise an interesting point about the mechanism of delivery and how we can best optimize that. When I said we immerse these scaffolds, prior to implantation, they spend about 15 minutes sort of soaking in this diprotamol solution, and then they're implanted. So in terms of understanding exactly how long the diprotamol is present in the defect site, that's something that we're not currently aware of, and definitely merits further study.
And how about the adenosine 2A receptor? Are there abundant receptors in that calvarial defect? Have you looked at that? And have you looked at trying to just do a receptor antagonist or agonist study to see if that triggers any of those bone responses that you want?
We haven't done anything with antagonists of the receptor. We know the A2AR is present on osteoblast and osteoclast precursors. And so, we have reason to believe that in a freshly created calvarial defect, there's certainly going to be, cells present that are expressing the A2AR and therefore are affected by the presence of diprotamol.
And then the last question, did you see any bone growing over the top? It looked like you had soft tissue, like just scar. Did you expect for there to be bone to migrate across the surface? Because the graphic that you showed is it's sort of inset and not flush. So what's going on the surface?
Right. So I think in the original intent, when we designed these scaffolds, the idea would be that we would have sort of the cap would be flush with the calvarium. When we actually got to the OR, the burr that was used was slightly larger than anticipated, and so you sort of saw that inset of the scaffold. I don't think we're particularly surprised by the presence of the soft tissue growing over top, as the design of the cap was not really so as to facilitate osteoconduction, but really to prevent soft tissue ingrowth from sort of filling the defect site. Yes, thank you.
Steve Buckman, Michigan. Very nice. I'm sort of curious because scaffolds really sometimes have a double-edged sword. There are some that actually prevent ingrowth and healing. There are some where if you put semi-permeable membranes over the top of a defect, actually not something in the defect, you'll get this tissue-guided regeneration and so on. So I may have missed it. Did you have a control without these scaffolds where you just use the medication itself? Because it would be very curious to find out. It's a great way of looking in a three-dimensional sort of way where that bone is coming from. But again, and I think one of the biggest reasons you probably have something in the middle is you're getting vessels that are actually now coming into it. But it would be very curious. I think one of the controls that may be missing here is what do you see without the scaffold with that drug? It would just seem to me you're begging for that. It's sort of a big question that you would have. It might even be better. It may turn out that the scaffold's not necessary, and I was wondering if you looked at that.
Yeah, thank you very much, Dr. Buckman. Actually, we in this particular study, there was no true negative control, nothing where we didn't include a scaffold and simply use diprotamol. But going forward, we will be certain to include that. You raise a very good point. Without having a defect where there is no actual scaffold, it's tough to say exactly how well the scaffold is doing filling its intended purpose.
Right. Thank you.
Thank you.
Thank you. Okay, the final paper, stem cells harvested from bone marrow and adipose tissue demonstrate differential healing mechanisms and union rates in murine model of irradiated mandibular fracture repair, presented by Dr. Ragnarsson from Michigan.
Thank you so much for the opportunity to present to you all today. In 2016, over 60,000 cases of head and neck cancer were diagnosed, with over 75% of these patients potentially requiring radiation. Now, as you all know very well, radiation makes our jobs really hard. Complications such as osteomyelitis, osteoradionecrosis, and even small amounts of bone exposure become very difficult to treat. We know that radiation impairs bone healing and causes bone injury via several different mechanisms. In our lab, we focused on the mechanisms of how radiation inhibits vascular regeneration, causes cellular depletion, and ultimately diminishes cell function. Now, in the lab, we've been focused on mitigating the effects of radiation on all of these factors, but for today, we're going to focus on the concept of cell depletion first. Our hypothesis was that if we're able to replete the cells that are deficient from a site after radiation, we can restore a normal bone healing situation. We chose to focus on two main cell types, ASCs, which are adipose-derived stem cells, and BMSCs, which are bone marrow-derived stem cells. We wanted to compare the efficacy of these two cell types in particular, as both are relatively easy to harvest and also part of the mesenchymal cell lineage in which cells directly can form bone. To test our hypothesis, we radiated rats at a dose of 10 gray and subsequently created a mandible fracture with external fixator placement. At the time of surgery, we implanted either ASCs or BMSCs, and 40 days later, we studied our primary outcomes, namely micro-CT, clinical union rates, histology, and biomechanical testing. Now, our hypothesis was that BMSCs would heal a defect better than ASCs for the simple reason that bone cells should heal bone better than fat cells. What we saw, however, was the complete opposite result. We saw that actually ASCs have a significantly higher union rate compared to BMSC implantation. As you can see here, with radiation alone, our union rates are about 20%, so pretty bad. With BMSC implantation, however, our union rates, both clinically and on micro-CT, rise to about 66%. Interestingly, however, our union rates with ASCs actually approach what we see without any radiation in the picture. Our union rates in this scenario were over 90%. Even after ASC implantation, bone quality was quite similar to that with ASC implantation compared to that after ASC implantation. As you can see here, if anything, the biomechanical strength is better for fractures treated with ASCs compared to what you see with even BMSCs, but both are relatively similar, indicating that the quality of bone regenerated from the ASCs is relatively similar to what we see with the BMSCs. Now, our initial hypothesis was that BMSCs would be better than ASCs because we thought that these cells would directly turn into bone. Given, however, that we saw that actually ASCs were better than BMSCs, we started to question why this was the case. We questioned whether these cells are actually turning into bone themselves or whether they're contributing in an indirect fashion in a more paracrine way. So we wanted to follow the progression of these cells after implantation. To do this, we implanted once again either ASCs or BMSCs, but this time the cells were tagged with a protein that would light up bright green after implantation if they were present in the tissues. Now, as you can see here, however, there is absolutely no green present within either the ASC or BMSC samples, indicating that these cells do not directly turn into bone. So what we know thus far is that ASC implantation leads to increased union rates compared to what we see with BMSC implantation, but that neither of these cell types actually becomes bone directly. Now, this leaves us with the question of actually how are these cells affecting fracture healing? Angiogenic osteogenic coupling is an important process required for normal bone healing and wound regeneration. Angiogenesis is the first part of this process, so our hypothesis was that ASCs would recapitulate the normal wound healing process given their increased vasculogenic potential. Now, BMSCs, which have higher levels of osteogenic gene expression but lower levels of vasculogenic gene expression, would be relatively ineffective in this scenario because they don't affect the first step of this process, which is angiogenesis. So we next wanted to understand the effect of these cell types on endothelial cell and tubule formation. So as you can see in these videos, you see that ASCs, when co-cultured with endothelial cells, form these really nice tubular networks. You can see the cells moving very quickly together. However, when we look at the BMSCs, when they are co-cultured with endothelial cells, these endothelial cells don't really do much. They just kind of sit there. Now, not only are these results true in vitro, they are also true in vivo. So you can see when we treat ASCs and implant them into a mandible after radiation, the number of blood vessels located at this site is significantly higher than what we see after radiation alone, and actually even similar to what we see in control animals without any radiation. We also realize that an indirect relationship is present in this case. So you don't need direct cell-to-cell contact to recreate this effect. We co-cultured ASCs or BMSCs once again with endothelial cells, but this time we prevented any direct cell-to-cell contact so that only the secreted factors from these two cell types would affect the endothelial cells below them. And as you can see, we see the exact same results. Once again, you see the nice intricate networks of tubules, whereas in the BMSCs you don't really see that much. We believe that this is attributable to higher levels of VEGF in the ASCs compared to the BMSCs, because when we look at the amount of VEGF in the medium secreted from these, we see much higher levels. And not only is this true of VEGF, we also see higher levels of HIF-1 expression in the ASCs, so once again, they're much more vasculogenic. Interestingly, you see much higher levels of osteopontin expression, a bone gene expression in the BMSCs compared to the ASCs, but this basically doesn't matter. It's the increase in vasculogenic potential of these cells that is the main contributing factor. So in summary, we see that when you implant ASCs into a defect in the setting of radiation, you improve bone healing to a much greater degree than what you see after BMSC implantation. Now, while we initially thought that this effect was due to our modulation of cellular depletion, it actually seems to be a modulation of vascular degradation. ASCs, because of their enhanced vasculogenic potential, recreate whole new networks of blood vessels, which then indirectly replenishes cells and recruits more osteoprogenitors, which are able to function normally in this new environment. Now, does this mean that we are recommending fat grafting for patients who have large mandibular defects in the setting of radiation? Absolutely not. What we are saying, however, is that potential additional studies of this particular cell type can enable the use of other technologies for conditions that we are currently not able to treat very well, using technologies such as distraction osteogenesis or bone grafts for conditions like osteorenonecrosis, recurrent head and neck cancer, and osteomyelitis, in addition to other conditions that commonly occur in the setting of radiation. I'd like to thank my mentors, Dr. Buckman and Dr. Levy, as well as Dr. Sederna and all of my mentors at the University of Michigan. Thank you.
Dr. Craig Bergfeld will be the discussant.
Thank you. Craig Bergfeld, Seattle, Washington. So I don't do basic science research, but I do treat a lot of mandibles that have been insulted either by radiation, genetics, or most fists, usually. And so I appreciate your work. Thank you for your presentation, and thank you to the University of Michigan for ongoing work in this field. I have a couple questions for you. Number one, you showed that these ASCs have both a direct effect and a paracrine effect. What I'm curious is, do you think these cells survive for a period of time? And if so, how long? Or do you think that they just kind of release their cytokine and have their effect that way? Number two, even though you showed the ASCs were better than the bone marrow-derived stem cells, both of them had an effect. So do you think that combining the two would have even a better effect if you mixed them together somehow? And third is I need this stuff in the OR tomorrow. So how do you foresee this becoming useful clinically? Do you think this is going to be a cytokine drug that we can give to our patients, or do you think that we're going to be harvesting stem cells and somehow putting them into mandibles that have been insulted by radiation or some other cause?
Thank you, Dr. Bergfeld. So to answer your first question of whether or not these cells do survive, so the answer to the question is we actually don't know if they survive or not, but regardless, they do seem to have an effect. I think what happens most likely is that they survive for a period of time very early on after implantation, and that time period is enough to release enough VEGF to affect vasculogenesis down the road. We haven't directly looked at whether these cells survive or not, but for looking at whether or not they're directly incorporated into bone. But because these cells don't actually become bone, we need to look further into whether or not these cells do survive or not, but they do seem to have an effect, and so I think it's very early on after implantation. With regards to the use of both ASCs and BMSCs, we have started to do some in vitro studies where we culture either ASCs alone, BMSCs alone, or ASCs with BMSCs all at the same density. And what we do find is that the combination of ASCs and BMSCs is actually the most osteogenic. So those groups had much higher levels of alkaline phosphatase stain, and this is all in vitro. I think when we apply this in vivo, I think it comes back to the concept of the number of steps and the sequence of steps required to recapitulate the normal bone healing and wound healing process. I think the ideal situation would be to implant ASCs first so that you can affect the vasculogenesis and affect the vasculogenic potential of this niche first, and then subsequently implant BMSCs once that niche has been established. Obviously, that would require multiple treatments, which isn't ideal, but I think in order to optimize the synergism and mix that with the sequence of steps necessary, I think that's what I would ideally recommend. And then the last question of how do we actually use this clinically, I think this is an analogous situation to what we see in fat grafting, which we've talked about a lot in this conference, and all of the FDA approvals that go with that. We've learned that the two main criteria are homologous use and minimal manipulation. And so these are the criteria that we're looking at in the lab now. We've decided to focus on figuring out a way to minimally manipulate the fat first. Similar to what we see in fat grafting, because if we can create a situation in which fat grafting is enough to provide that vasculogenic effect, similar to actually what we see in other tissues, and that's enough to use as an adjunct for bone healing, that's our first approach to this step. But I think ultimately we have to figure out a way to address both of those concepts before moving forward with any approval, but I think we like to use the fat grafting model as our analogy for the best way to go about this. I think also your question in terms of whether a drug is appropriate or not, I think that would just take a lot longer compared to using autologous tissue, and so that's why we've used the approach with ASCs that we have.
Great, thank you.
Thank you.
Brian Gassman from Cleveland. Very nice job. I always appreciate watching Steve's mentees go on to do great work like this. A couple of things. One is from a clinical standpoint, these cases that you're describing are really very standardized. These are generally stage 2, stage 3 ORN. Usually what happens is a third molar is pulled and then you get a classic angle of the mandible fracture. That's almost all the time what happens. Otherwise, there's tons of stage 1s and 2s that are managed by oral surgeons that we as plastic surgeons never see. So from a modeling standpoint, where I see this maybe translatable is that when patients are going to have a bone exposure after ORN, they're going to need their teeth removed, that's the time to intervene. I have a hard time believing that once you have a fracture, that you're ever going to get great healing, because you have other issues too when you go in there. You have a big problem with soft tissue. When I put a fibula in, I can't put enough skin in, even though I'm not taking any skin out. And we've still seen where we thought we cut to normal looking bone, and I just took a patient back where the fibula is alive, the bone's sort of alive, but there's still a problem with the native mandible. So I think getting to it before you get a pathologic fracture, for me, is really where you're most translatable in this research. The other issue from a scientific standpoint is we know that mesenchymal and bone marrow-derived stem cells act differently. We've seen that in some of our VCA presentations over the years. And we have to be careful as plastic surgeons that we're not just we have a hammer and everything's a nail, so everything has to be done with adipose-derived stem cells. I think it would be very important to look at other mesenchymal-derived stem cells and to figure out whether this is a fat-specific detail, or maybe others may actually be better from a bone healing standpoint. I mean, clearly you've opened that door, and I think you personally should proceed into it.
Thank you. I totally agree with everything. I think that the ideal situation in which to apply this would be as prophylaxis, and also in the setting of a model focused on osteoradionecrosis. We don't have that model in our lab yet, but we're focused on developing it. I think that also you're right that just because you have a hammer doesn't mean you have to use it on a bunch of nails or whatever. I think that this scenario that we're talking about is particularly related to radiation, in which we know that there is vascular degradation that occurs. I think that we do have to examine, which cell type is the best, and even timing, I think, is another important point, whether chronic defects are as appropriate for this process as acute defects, and I think all of those things need to be examined. And I think now that we have shown in this acute model that ASCs are effective, I think, as you said, it does open the door to look at other models like osteoradionecrosis, which would actually be even more ideal. Thank you.
Thank you. That concludes this session. We'd like to thank all the presenters for staying on time and for your excellent presentations. Thank you.